So the first question is an anonymous question, which always frightens me, but this I don't think is particularly disturbing. Could Natasha or Maddie give an update on the drug tariff proposed changes?
ASCN are meeting with Part 9 Drug Tariff Department of Health. We have met recently. They have the most recent changes that they are advertising for a specialist stomach care nurse to help with the process, which we think is a positive step forward, because then there will be somebody with experience and expertise who is advocating on your behalf at the table. But that's all I can tell you, I'm afraid. Anything to add to that? No.
Okay, is that as far as we're going?
Yeah, well,
okay.
I think so. What, did you want me to make something up? Because I can.
Not at all. No, I just wanted to make sure we were happy that pretty much covered it. Okay, so the next question is for Dominic Slade. And I think this is a fairly easy question to answer. Can a patient ask to be referred to Salford Royal if they have a peristomal hernia, knowing that you are a centre of excellence if you live outside the catchment area? Dominic.
So I said I wasn't touting for business. And genuinely, it is important that there are other people around the country that also I could recommend that are doing peristomal hernias in numbers. But by the same token, you have the right as a patient to demand or ask to be referred somewhere else. And it depends who you're seeing. It's sometimes more helpful for Gordon and I if it comes from your colorectal team, if you feel that you're not happy with what you've been told, or if you would like a second opinion. You're perfectly entitled to ask for that. But I spoke to someone after the talk who's no longer under a team, and so you can go to your GP and ask to be referred. But much as we'd love to help, I don't want to then have somebody referred to us and then have a very miserable experience waiting 6 months to get into our clinic, because that is sort of the wait at the minute. It's not easy for us to see new people. But if you would like to come and see us, you're more than welcome.
So I'd just like to pick up on that question, because I think it exposes a misconception, which I was talking to, I think, Marlene about actually this morning. Most of you, I suspect, will not realise that the NHS Constitution entitles you to be referred anywhere in the country you wish to be. Now, Tony Blair, I think, in a masterful exercise of spin, told people a few years ago that they would create the right for patients to be seen in any one of 4 centres they wanted to go to. So actually what they'd done was restrict your choice from anywhere you wanted to 4 centres that might be okay to you. But the truth is you are entitled to be seen anywhere you want if your GP is prepared to refer you there. And that right still exists. The interesting thing is most people don't know they possess that right. I think most GPs don't realise that their patients possess that right. And therefore, people are still seen locally. Now, that doesn't mean to decry local services. And often patients want to be seen locally because it's easier and closer to home. But sometimes for specialised and more complex problems, people are prepared to travel to get the right advice. So what I would say is you're entitled to be seen anywhere. The problem, as you've heard from Dominic just now, and again, this is something I discussed this morning, is if you had a restaurant that made really good burgers, you'd make fantastic burgers, you'd be on, TripAdvisor, everyone would come and eat your food, and you'd have a queue out the door, and you'd make loads of money. So you'd make the restaurant bigger, then probably open a second one, 5 miles down the road, because excellence generates income, and then income is used to develop the brand further and ultimately franchise, etc. Unfortunately, as I've found over the last 30 years, the precise opposite happens within the NHS. So excellence just means you get more and more people who want to come and see you, and a hospital management which is not prepared to invest, if there is any money to invest, in your service. So all you get is a longer and longer waiting list, which then creates dissatisfaction. And unfortunately, that's a problem with the system which is broken. So the short answer to your question, Gwen, as you've heard, is yes, you can be seen, get your GP to refer you, but you may need to wait if you want to see a specific person in a specific centre. Okay. Next question is for Uchu. Do you think patients feel empowered to speak up and explain that they have a different GI tract? If so, what are your thoughts on how to improve this?
I feel all patients should be empowered because it's your body. You know your body better than any healthcare professional. And a lot of the time in clinic, or when I'm seeing patients on the ward, or when I'm seeing patients, I always listen to what they're saying. And if they feel shy, I say to them, you know your body better than I do. And I try to get them to explain as much as they can to me so that I can understand it from their point of view. A great example, I had a lady with anemia, iron deficiency anemia, but she's also got a mix because she's also vitamin B12 deficient and also she's folate deficient as well. But her blood results weren't showing that she was deficient, but from what she was telling me and her past experiences of being anemic, she was anemic, but her blood results weren't showing it. So I went off and did some investigation, spoke to my consultant, shared the papers that I'd found, and because this woman was really dehydrated, her blood had concentrated, so you weren't seeing a true picture of her iron state or her vitamin B state or her folate state. So we then looked to see how we could correct and adjust, and we spoke to our medicines information department, and they were happy to grant us to give her iron earlier instead of waiting for her to become hydrated and then to see the deficiency in her blood. So I think that's a really good example of actually listening to people and empowering people to have that voice. And if you don't feel empowered, just knowing yourself. I went to a great session, the meditation session, and it's about feeling comfortable with yourself. And you have to have that comfort that this is your condition, it's your body, you know yourself better than anybody else, and just say, I have an altered GI anatomy, and if you don't understand your anatomy, again, as I said, get them to speak to your teams, refer, or ask them to look at your medical notes, and they should have a good description of that. So I would say don't feel that you can't, or don't shy away from it. Anybody else got anything to add?
Yeah, I think it's also really helpful just to be really clear in what you're saying to your GP. So if your GP is saying, I'm not going to give you care for that, if you repeat back to them, okay, so I've got these symptoms, this is what's happening for me, I've had a little look at the NICE guidelines, they say this, but my understanding is you're not going to give me treatment. Can you make a note of that for me, please? Generally, that might frighten them into doing something. Equally, as she was saying, it's a really good idea to speak to your team. Your stoma care nurse could write to your GP and explain your different anatomy. Your dietitian could. Anyone can write to your GP who has more understanding of these things. There's loads of downloadable information on the IA website. You use the resources and tools you have available. If you're tech savvy or you've got family members that are, get them to have a little search of the NICE guidelines, see what you can find online and take things to them. Print them off. Sometimes my patients might feel too shy or too embarrassed to talk to their GP about certain things. Write it down and pass them a little note. They don't care, they just want to know and they want to help, but sometimes they don't know all the answers. And it can be quite important to say, if you're going to refuse me care for this, can you just write it down in my record that you've made that decision today, please?
I think the other point I would make, Uchu, is that it's with all due respect to our colleagues, it's important that we don't overestimate the level of knowledge that some of our colleagues in primary care have about even simple things like gut anatomy. I saw someone in my clinic actually this week who was referred by their GP on a 2-week wait large bowel cancer pathway because they'd had a positive stool poo test from their ileostomy, having had all of their large bowel previously removed. And the GP didn't seem to be aware that you can't get large bowel cancer if you haven't got a large bowel. So they clearly didn't kind of join those dots at all. And that was a qualified GP. So it's important. They don't always know best, even about simple things, actually.
Definitely. And if you think about it, we are in this world and we understand. But the condition's pretty rare. If you think about it, how many patients does a GP have on their book with these conditions versus the amount of patients they'll have with hypertension or diabetes or asthma. So they'll have more knowledge of those conditions compared to the conditions that we see on or experiencing on a regular basis. And another good example, actually, we asked the GP to do a urine sodium test, and instead of just doing one sample of urine sodium, they asked the patient to do a 24-hour urine collection and then ran the sodium that way. So if you are asking for urine sodium, it's just a one-off, not a 24-hour collection.
Okay, next questions, and this is for Natasha. Mike wants to know, or wants to say, 600 stoma care nurses in the UK, and I wasn't sure whether your number was for the UK or for England and Wales, is a very small number. Do you have any optimum that these do you have any optimism that these numbers will increase year on year?
Oh, I have a lot of optimism. That is accurate for the UK, sadly. But I'd give up if I didn't have optimism. I think part of the advancing stoma care services is about raising our profile. So it is about enticing experienced nurses into the specialist profession. So that's one of the really big things that we're hoping to achieve. It's also worth noting that part of our difficulty with the project is that we're not great at data collection in stoma care. So that is an estimated number, and of that number, some might be dual qualified, so stoma care and IBD, stoma care and colorectal cancer, and it may not capture all. One of the reasons that we started the Advancing Stoma Care Services was because, I don't know if you've heard, but in Scotland they changed sponsorship rules, and as a result, stoma care nurse numbers have dropped rapidly. So we are keen in England, and that's why the project's starting in England, and that's where all our contacts are, to make sure that that doesn't happen here and for the rest of the UK. But yes, I am, of course, optimistic. Otherwise, I'd go and work in Waitrose.
Okay, next question. And it's not clear who this is directed at, but I think it should be directed to Mr. Slade, really. And it's from Stephen, who wants to know how much progress has been made by research to avoid surgery caused by Crohn's and colitis, specifically medicines to stop or control inflammation in the bowel.
It's a good question, and I'm not sure I'm the most qualified person in the room to talk about it, but I can tell you in my surgical lifetime and Gordon's, the number of people that we're operating on for inflammatory bowel disease is dramatically reduced, mainly because of the introduction of the antibody-based immunomodulator drugs, all those ones that I can't pronounce, like vedolizumab and so on. And not only that, but there's been an expansion in those drugs. So there's 5 that are used regularly at the minute. And so when one becomes less effective, you can have a trial of one of the other drugs. And they definitely keep patients away from surgeons, which is a good thing because surgery, particularly for Crohn's disease, it doesn't cure the condition, as many of you may know who have that condition. What it does is it deals with symptoms, but the end result is that you lose some bowel in each operation that you have, and you're always potentially at risk of the complications of surgery. So if it can be dealt with by medicine, that's so much better. There is a lot of research ongoing, and you know, I have given just how quickly all those drugs have expanded in such a short period of time, and the fact that changes to the way that we develop medicines like artificial intelligence means that the production time of those drugs is getting shorter, that there will be other drugs on the market that will be as life-changing.
That's a good answer, Dominic. And the other point I would make is there is undoubtedly now very considerable evidence that the amount of emergency surgery we're undertaking for inflammatory bowel disease is vastly less than it used to be. It's actually pretty rare now to have to do an emergency colectomy for colitis. We are still doing some elective surgery for inflammatory bowel disease, but we're actually doing considerably less of it than we used to. Often, though, the problems are that when we are having to offer patients surgery for inflammatory bowel disease, it's because biologics have ceased working, and often there's a dilemma there about whether someone's potentially put off for quite a long period of time a decision to undertake surgery because they've gone from drug A to drug B to drug C to drug D. And actually, with hindsight, when you ask the patients, they'll often tell you, you know, I've had a couple, I wish I'd just jacked it in after the couple of drugs didn't work, because actually I've just been marking time and my quality of life hasn't been very good. But the overall answer is yes, we're operating much less frequently. Uchi, do you want to address that?
Yeah,
As a purveyor of some of these poisons.
Sorry. That was a brilliant answer. But not only have the number of drugs increased, but the way we're using them has increased. A good example is when I first started working in IBD, so a drug called infliximab, which a lot of you might know, we used to just give it randomly. So if you're feeling symptomatic, come in and we gave it to you. And then it developed schedules, so you'd have it a loading dose and then you'd have it on a regular basis. But now what we're finding actually is if people come in and they're acutely unwell, we're now changing the regimens and the way that we give the medication and the dosing, and maybe shortening the time between them. So not only the number of drugs increasing, but the way that we're using them is increasing, or changing, which is really good actually, because we're getting a lot more experience with these drugs, and our commissioners, for once, are working with us to help us with these pathways, because they know the medication's a lot cheaper than surgery or any potential surgical complications.
Okay, next questions, and I think this question is directed to Natasha really, although it's not clear whether it's specific or generic. Do you, and I don't know whether that means do you, Natasha, or do stoma nurses have the ability to refer back to surgeons if you come across an issue that needs refashioning or surgical input? Or does a patient have to go back through a normal referral route again?
As far as I'm aware, I would refer back to our surgeons directly. So the only caveat to that is obviously if you're new to the area and you didn't originally have your surgery with any one of my surgeons at my trust, then I might seek for you to go back to your GP, but we could always write a letter of support to your GP to help them direct signpost them who to refer back to. So yes, in my opinion, and certainly in my area, stoma care nurses do have that ability.
I'm not going to ask the next question to our panel. It's a question about vitamin B12 deficiency in patients with ileostomies and whether it's likely and what tests, because we've really addressed that, I think, brilliantly in Sophie's letter. What I will do is, if my surgeon were to tell me that it was now possible to reverse my ileostomy, is it a no-brainer, or are there factors to consider which might suggest the opposite? Dominic, I think.
So I didn't say in my talk, I know it's about an ileostomy, but I didn't say in my talk that the best repair for a peristoma hernia is to get rid of your stoma. But of course, for some people that isn't an option. And for some people, either their stoma is permanent and there's no bowel downstream, so you couldn't reverse it if you wanted to, or that the stoma was made to improve your quality of life from, say, problems with chronic constipation, and reversing that stoma, again, is not to be contemplated. But no surgery is a no-brainer. You know, I mean, of course, you know, we do surgery because we enjoy that part of our work. In fact, if you speak to any surgeon, you know, the time spent in the operating theatre is one of the most sort of enjoyable parts of the working week, because you're doing something very practical that helps resolve problems for patients. But it comes at a cost. All operations do. And, again, Gordon and I see the outcome of operations that haven't gone right, and they sometimes don't go right in our hands too. So I would never use the term, and I don't mean to, for the questioner, I don't mean to put them down, but I would never use the term no-brainer, because every operation, whatever you have, needs a lot of thought about whether it's right for you. And, you know, as I always say to people when I'm talking about any operation, you know, there's what you stand to gain from the operation and what risks you're undertaking if you have an operation. And that is that sometimes it's difficult to sort of work all those out, but an individual, if you give them all the information, should be able to balance that argument and see whether it is a no-brainer for them or not. But, you know, every operation has a potential to go wrong, and you have to consider that too.
Okay, next question, I think for Natasha. How do you stop a fistula bag leaking?
Oh, Lord. Honestly...
So should we move on to the next question?
I just think if I had the answer to that, I would be in the Bahamas.
Yeah.
You need to go back to your stoma care nurse. That you need to go back to your stoma care team, and you need to work with them to find a solution that works for you. There will be one out there, but it isn't always the first, second or third solution, I'm afraid. Fistulas are notoriously difficult, but please, please go back to your stoma care team, because they are the ones that will help you.
I think the other issue, without wishing to tread on your toes, Natasha, is it's very important that when we're talking about how we manage fistulas compared to stomas, there's a fundamental difference. A fistula is almost always an accidental, unplanned or disease-related discharge of bowel onto the abdominal wall, whereas a stoma is a planned thing. So a fistula will happen, unfortunately, where it will, whereas a stoma is usually there because someone has put it there. And therefore, if you have a patient with a fistula, actually, I think with the very best will in the world and with the very best stoma care in the world, it can be impossible to stop a bag applied to a fistula from leaking, because that's a product of how much is coming out and the shape of the abdominal wall, and it may not be possible to alter that. So sometimes, that is the main reason, actually, sometimes, why I have to talk about operating on a patient with a fistula who is terrified of having further surgery, simply because my colleagues cannot do any more to try and deal with the fistula. Okay, question from Cherry, which I think is for Sophie. Given the high reliance on antibiotics, why are pre- and probiotics, or why have they been dropped from NHS prescriptions? So there might be a bit about Uchu too there.
Yeah,
actually.
I mean, I'd love to hear Uchu's thoughts on this, but I think probiotics are really exciting. It's really great to see us having access to these sorts of things, and the microbiome itself is a really exciting area of research. But it's still really young research. We're not really sure, despite the Zoes of the world and everybody else who's telling you that they know everything about it, we really don't understand the full impact of taking a probiotic supplement, for example. There isn't vast amounts of research. And for you guys, especially who don't have a colon, there's no research at all on whether you should be taking probiotics or prebiotics for that matter. So I think for something to be available on prescription, there needs to be a lot of research, especially something quite expensive like VSL. And Uchi can speak to this, hopefully. But I think we need to, perhaps, all of us, nationally, internationally, need to take a little bit of a step back from the probiotic chat and go, OK, let's learn more about this before we start investing lots of money and worrying too much about it. But, of course, that's never going to happen because there's so much money in these kinds of products now.
Yeah, I would agree with you. When it was taken off, we wrote to NHS procurement via our procurement team to find out, to get a little bit more information why, and to London procurement as well. And it was just that there was no evidence to demonstrate its effectiveness versus its cost, and that's why it was removed from prescription, unfortunately. You can buy it over the counter if you feel that this is something that you'd like to pursue or to use, which is an expense in itself because it's pretty expensive. But there's one of our patients said that she gets it on a subscription, and she's a member of this site, so it's a little bit cheaper. So there are those things out there if you wanted to try it. But it's just, again, we just can't demonstrate evidence-based value for money in improving patient outcomes at the moment.
The other thing, just to say on that, is that if you were on VSL3 on prescription, my understanding is that there's a company called VivoMix, and it's the same as VSL, but it's cheaper and it's in capsules. So if you were keen to continue with something like that, but you're noticing that VSL is really eating into your budget, then VivoMix is another option for that. It's exactly the same. It's made by the same guy who invented VSL. It's just a cheaper presentation of the same thing.
And also, if you shop around on Amazon, For example, Lactobacillus plantarum 299V, for which there is actually some randomized control trial evidence. It's mainly about bloating in patients with functional bowel disorders rather than colitis, for example. But there's some Canadian research which demonstrate that. And again, you can buy that on Amazon. It's not prohibitively expensive. But I think, to be fair, we cannot expect the NHS, i.e. the taxpayer, to put their hands in their pocket and pay for medication in the absence of robust evidence from randomized control trials. I don't think it is reasonable, actually. Okay, we've got 3 quick questions to finish with. When considering surgery, this is for Dominic, I think, is there an alternative to something like TripAdvisor as to how you would decide where to have your surgery? What questions should you ask? And is robotic surgery offered everywhere? So there are actually 3 cheeky little questions in one there.
Okay. So, firstly, I don't think there's a TripAdvisor, but maybe this is an opening for my son who's quite good at IT to make a website. But there are professional associations, and the Association of Coloproctology has a significant investment in patients, obviously, because we wouldn't be around if you weren't around. And there are patient representatives, and I think maybe the first thing to do is to sort of, if you're really stuck and there's no one that can tell you about who might be your surgeon for a particular thing, to get in touch with them and the patient representatives. Obviously, stoma care nurses and anybody else who you might have a close relationship with professionally can give you some advice as well. But I think what I was trying to do in my talk is to point out that you may well have had brilliant surgery from the person that treated you for your ulcerative colitis, but they may not necessarily be the right person to do your peristomal hernia repair. So it is worth asking around and seeing. In terms of robotic surgery, fascinatingly, if you look at where robots are around the country, they are disproportionately placed in the most affluent areas of this country. In the city of Manchester, the robots that are available for surgery are mostly in South Manchester, and we've got one in our hospital, mainly for urological cancer. And it is a real, currently, quite a part of equity of access to patients that those people who should be offered robotic surgery may not live in an area where they're going to get it. So no, it is not easy to access at all. And whilst it may not be the answer to everything, I think it's just a tool, but it's a way of doing surgery that I think is the future, and that people should be given the option. And the middle question?
What questions should you ask? But I think that's a kind of generic thing, really. What I will say in relation to the first question is there are actually websites. There's iwantgreatcare.com or whatever it's called. I would caution. I would advise great caution in looking at that. You need to know that there are people who will encourage their patients, twist their patient's arm to post positive reviews of the care they've received. You may argue whether that's scrupulous or unscrupulous, but sometimes I've looked at these websites and thought, crikey, I wouldn't go and see him if they was the last person alive. And there are 200 positive reviews of this person. There's a reason for that. So I'm afraid you need to exercise caution and a degree of cynicism, I think. Last couple of questions, again for Dominic, sorry. Regarding an ileostomy surgery, if doing open midline surgery, are the procedures different now from 25 years ago in terms of closure and the use of mesh? They are, yes. Let's just put it this way. There are just certain conditions or certain times where open surgery is the right operation to do. That is the safest, and whilst it's a big operation, if you've got a big problem, you often need a big operation. We possibly are in a better place in relation to sort of understanding things about mesh and reducing the potential for hernias to come back. But I think the
concern I have at the minute is, unlike something like a medicine that is very easy to put into a randomized controlled trial and to be able to say, that this medicine has value or doesn't, it's much harder to do that with surgery because there's so many aspects to it. And there's not an excuse for why the research in hernia surgery is so poor, but the fact is, it is. There are precious little randomized controlled trials in hernia surgery, 4 that I can think of any quality, and the rest is all good people saying, I did 25 of these and they went well. And that's all we've got. So the world is changing because, everybody keeps saying the evidence we've got so poor, we've got to make it better. The manufacturers that make mesh are definitely coming up with better meshes and so on. And I think, surgical techniques they're not changing. One of the reasons why robotic surgery is so attractive to surgeons and to patients is it enables us to do all the things that Gordon and I do in a big open operation on the end of a camera, because the instruments are jointed like your wrists, so you can do that kind of surgery on the end of a camera. And the benefit of that is it reduces the risk of you having wound infection, reduces the risk of you having certain complications, and certainly in robotic peristomal hernia surgery, your risks, your complication rate is halved, and your risk of being readmitted as a patient is halved as well. So there are definitely benefits coming from that technology.
Thanks, Tom. I'm going to draw this to an end by thanking all our speakers for joining us on the panel. I'd be very grateful if you would show your appreciation in the usual way, and then I'm going to wrap up the conference. Thank you.